thank you to the charity for inviting me to come and do this talk. So I can see that there are about 80 of you out there watching. I imagine that some of you may have just received a diagnosis of polycystic kidney disease recently, which may have come as a shock. Others of you may have known about it for a while, may have had some family members affected by it. And indeed, some others of you may be real veterans and have had a number of the treatments that you've heard about already today. And indeed, you may have even had some of the treatments that I'm going to talk about now. So my job as a surgeon in Bristol is partly to provide transplants, but also to provide other surgical treatments that might become necessary for people with polycystic kidney disease. So I'll start just with this slide. This one takes you right from having a normal and healthy kidney all the way through to having a very badly diseased polycystic kidney and kidney failure to go with it. So I'm sure you've heard about this, but the kidney is as it is there on the left-hand side when it doesn't have disease. And then when we have polycystic kidney disease, lots of small fluid-filled sacs appear in the kidney, and they start to obliterate the normal functioning part of the kidney. And that's what causes the problems. So first of all, you can see that the kidney starts to get bigger. And then indeed, as we go further over to the right-hand side, much bigger. And some of you will know about some of the effects of that already. The other thing that happens is that the kidney function, which is represented by the solid red line in this picture, it starts off normal, but then over time it gradually decreases as all of those small fluid-filled sacs just destroy the normal functioning parts of the kidney. And the dotted red line at the bottom represents the point where the kidneys aren't functioning well enough to keep you going, and we need to do something to help you at that point. So this picture just shows us the normal kidney anatomy. In this one, both of the kidneys are pictured as healthy. You probably know this, but they're found at the back, and if you put your hands up just under your ribs on both sides, that's where your kidneys are, just tucked in there. And they take their blood supply from the big blood vessels at the back there, and then they produce urine, which goes down the ureters into the bladder, and then you pass urine. Allowing for a bit of artistic license here, this is what polycystic kidneys can come to look like. And this is effectively a scale diagram. These would be sort of moderately to large size as they go, but you can see that they take up an awful lot more room, and so they push all the structures that are nearby, and that can be the stomach, the bowels, sometimes even the lungs just above, and they can push on nerves and things in the back as well. This is another way at it. This is the 2 CT scan images, and what that does is uses X-rays to take slices of your body. The one on the left-hand side has red lines drawn around some normal healthy kidneys, and they show up as white, and that's because of some contrast that's been given through the vein. And you can see that they're quite small, and that they're at the back of this person next to their spine, which is that bright white thing in the middle. If you look over on the right-hand side, what you see is someone who has polycystic disease. And again, we've drawn red lines around where the kidneys are. Now, you can see, first of all, that they're both much larger with disease. And you can see that they've lost that bright grey or whitish colour, and that's because the normal functioning parts of the kidney have been obliterated. And you can also see in this particular person that their liver, which is the larger thing, looking at this picture, it's to the front and to the left. Their liver has also got some cysts in it. And if you look at the non-polycystic disease person on the left, their liver's just sort of a fairly even greyish colour because it doesn't have any cysts. So you can see that polycystic disease can cause a problem. And again, some of you will know a lot about this, others not so much about this. So as a surgeon, one of the things that I'm often asked to do is to remove a kidney. Now, the very fact of having polycystic kidney disease on its own doesn't mean that we have to remove a kidney. If they're not bothering you and they're not too large, then we just leave them alone. And that's what we prefer to do. However, there are a number of reasons why we might want to remove one or both of them. The commonest thing I see people with in my clinic is pain caused by a kidney. And again, they'll often indicate that the pain is there at the back, perhaps, sometimes even coming around to the front. And that can be on one side, it can be on both sides. Usually one side is worse than the other. You can also find that people are troubled by infections that keep on coming again and again. And some of you might find that you've been put on antibiotics all the time in the community to try and stop that from happening. And others may have been in and out of hospital with this type of kidney infection. Again, if that keeps happening, that could be a reason to remove a polycystic kidney. And now we move on to the reasons that are because of the sheer size of the kidneys. And when they get very large, as I was mentioning before, they can start to press on your stomach and on other parts of your bowels and intestine. And that can make you lose your appetite or find it hard to eat, and certainly not eat as much as you used to. And that can be a reason to take them out. One of the most severe reasons to take them out would be if they actually affect your ability to breathe properly. And that's if the kidneys get so large, they start to really push upwards onto your diaphragms and into your lungs. And that's quite an unusual one. But again, one I have come across. If that were happening, then certainly we'd be interested in seeing you to talk about taking out one or both of them. The last one on the list there, to make room for a transplant. We'll talk a lot about the transplant operation in a minute and about the reasons that polycystic disease can cause a problem. But again, this is the reason that we often talk about. If I was going to remove one of your polycystic kidneys, or indeed both of them, I'd bring you into the hospital up at Southmead in Bristol and admit you. And we then give you a general anaesthetic and make an incision down the middle of your tummy. And that would be between the muscles so that we can stitch them back together nicely at the end. In this way, we can reach either side and pull out the kidney that we want to remove. And the recovery from this procedure is usually about a week. And some people will advise to go to the intensive care unit, perhaps for a day or two, just to be on the safe side. Great. If anyone's a little bit squeamish, then perhaps look away just now. But what we have are some specimens of what these kidneys can look like. And there's a normal, healthy kidney in the middle for comparison. These kidneys can look very frightening, but perhaps a way to think about it is that all they are is fluid-filled sacs, something like water balloons or water bombs, if you like. Now, some of them, there are different colours, and that's because some of them have had some bleeding into them at some point. It's very rarely a significant amount of blood. It's more likely to be a teaspoonful or that type of amount, but certainly it can give you these interesting looking colours.
Sam, can I just jump in?
Yes.
Somebody's asking how heavy are cystic kidneys in comparison to a normal one? Yes, I think that it depends on the size of the kidney, I assume, but it's
a very good question, and we do always weigh them because it can make a difference to your dialysis requirements and so on. But the smallest I've taken has been about 1.5 kilograms. The largest I've taken has been 6.5 kilograms. So they can be quite heavy, certainly if you've got 2 of them at that weight. So it can be an interesting way of losing weight as well.
Thank you.
So moving on to the treatment for renal failure, I've talked so far just about removing a polycystic kidney and the reasons why we might do that. So I'll move on to the surgical treatments that we have for kidney failure, and by that I mean end-stage kidney failure. So the first treatment that you might have heard about is hemodialysis, and that's where we access your blood, pass the blood round a machine, clean it, and then give it back to you. Now, in order to do that reliably and regularly, we need some way of accessing the circulation. And that way can be through what we call an arteriovenous fistula, or an AV fistula, which I'll talk about in a minute. Or it can be through a line which we place in a vein in the neck. Now, some of you will know all about that, and others won't know so much about it. But that's hemodialysis. The second treatment that we have for kidney failure is called peritoneal dialysis, or PD. And for that, we put a plastic tube into your tummy, and then that's used to pass some special fluid into the tummy. And then that fluid will sit there and dwell for a while. And all the poisons, the toxins, the urea, the phosphate, the potassium, and other things, they then seep into that fluid. And then you learn to drain that fluid out again through the tube. And you do that 3 or 4 times a day. So that's a completely different way of doing it. Now, the last treatment, and the best treatment that we have for kidney failure, is a transplant. And a transplant can come from a live donor, and that might be a friend, a relative, someone you know, or indeed someone from somewhere else who's agreed a kidney exchange with you, which you might have heard about. The other type of donor that we have is a deceased donor. And that means getting you ready and prepared and going on our national waiting list. So very briefly, I'll just talk about what we do to make an arteriovenous fistula. Now, this is a classic diagram from 1955, which shows the first type of fistula that was made. And it's between the vein that runs along the outside of the wrist and the radial pulse, or the radial artery, which you can feel there if you feel for your pulse at the wrist. Now, what we do is we make a little cut just there with a local anaesthetic, and we stitch together the vein and the artery. What that means is that some blood from the artery will go into the vein, make it bigger, stronger, and more easy to feel, so that our dialysis nurse can come along 3 times a week and find it very easily, so that they can start your hemodialysis. Now, we can make it at the wrist. We also have options at the elbow and indeed other places, but that's the basic idea. So moving on to talk about a transplant, I'll use this diagram again, and it shows again the kidneys at the back in their normal position. Now, when we do a kidney transplant, most of the time, and also most of the time with polycystic kidneys, we leave your own kidneys where they are, and then we give you another one, so that most people with a kidney transplant will actually have 3 on board, and that can even go up and up. So the most I've seen someone have is 6 kidneys within them at one time. Now, that's quite a lot, and I think that was close to a record. But the situation here, you can see that we've got the diseased kidneys just minding their own business, and what I've done is plumbed in the new kidney a bit lower down in the pelvis. And all we have to do is make 3 connections. And it's a little bit like plumbing, but with soft tubes. And we have to connect, first of all, the red, if you can see the pointer there, the red vessel, and that's the artery, and that will take the blood into the kidney. The second connection is the vein, the blue vessel, which will take the blood out of the kidney. And the final connection is for the ureter here, to take the urine down to the bladder, which you can then use to pass urine normally. When we're coming to do a kidney transplant, this is the type of incision that you'll have, and it might be a bit more vertical. I make mine a little bit more horizontal. It doesn't really make a difference in the end. It'll be on one side or the other, and we'll usually decide which side on the day of the operation.
Can I just ask, why do you choose to make your incisions in that way?
It gives us, first of all, the thing we always need with surgery is the best access to the place we want to get to. And so going in there provides access to those blood vessels, the iliac vessels, which are the big red and blue pair sort of at the back here and here. So we want access to those blood vessels to plumb in the kidney. We also want to be quite near to the bladder. And so putting it lower down is very helpful in that regard. The other thing about this cut is that it's it's again moving around the edge of the muscles. You can just about see on this person that they've got a bit of a sort of a six-pack with their rectus abdominis muscles, and it's just avoiding the edges of that. And certainly when I do it, I avoid cutting the rectus muscle if at all possible. Some more pictures. On the left-hand side is much the same as the previous one that you've seen. And then on the right-hand side is showing where we've moved everything out of the way. So the peritoneum, which is in there, and the bowels and things have all been moved up and towards the middle to reveal the blood vessels at the back. And then the new transplant kidney is the one that's sitting there looking at us. And that looks nice and happy there. And this is probably my favorite picture of a kidney transplant, because it just looks like that the iliac fossa, which is the wing-shaped part of the bone here with the muscle, it's just been made to have a kidney just slotted in nicely there. And when the operation's finished, that's usually where it sits, just there. So again, if anyone's squeamish, very sorry, some more pictures coming. This is a kidney which has been freshly retrieved from a donor. It's just in the palms of my hand there. And what you can see here is the artery, which is usually shown in red on the diagrams, and we'll take the blood into the kidney. Then we have the vein here, usually shown blue on the diagrams, which will bring the blood out of the kidney. And then this last one here is the ureter, which will carry the urine. And all the blood has been flushed out of this kidney. So it's now showing, it's a slight pale grey colour. And that's again, flushing the kidney after it's just been removed, making sure all the blood's come out and making it all nice and clean and ready to be transplanted. This is the scar that we would leave behind after a kidney transplant. This is quite a slim person, and this is about 6 weeks after the procedure. It's still got a pinkish colour to the scar, but over time, over a number of months, that will fade to a white colour, so it will become less and less noticeable.
Question here about the position of the transplant. So someone's asking, is the position the same for men and women?
Yes.
Make a difference. Yeah. It is the same.
No, it's the same, exactly the same. So after a transplant, you can expect to be in hospital about 1 week. Some people will get going a bit faster than that, and other people will be slowed down if the kidney takes a while to wake up and so on. But on average, about a week in hospital. The thing that worries people, particularly the gentlemen, is the catheter. Now we have to pass a catheter into your bladder and then leave that there for 5 days on average. And we have to do that to measure the amount of urine that we're getting from the kidney, because that's the most important indication that we have of whether it's working or not. Some people will put a little plastic tube in the wound to drain out any fluid that oozes out on the inside. And we'll usually remove that after 1 or 2 days. The next one there is pain relief. Now, when you wake up, it can be sore, and we like to give you as much pain relief as we can to stop it being sore. Firstly, that comes through the vein, and then later on it will be from tablets to go home with. And then, all of that being done, we just want you to recover, to get back on your feet, eating and drinking, everything working, going to the toilet and so on. And then we'd like you to walk out of the hospital. So that's hopefully just a brief idea of what you'd be in for a transplant. This is a bit of a busy picture, but I thought I'd just put up some survival figures. But what it means overall is that you can expect to be alive and you can expect your kidney to be working after a year, and that's reflected by all the numbers in the 90s there. And our figures are shown, and then the national figures in brackets, and there's no real difference between them. Of course, some people will find that the kidney's not working after 5 years, but that's not many of you. Again, we have on average about 200 to 250 people on the waiting list at any one time, including around 9 or 10 children. In fact, I think it's currently more than that. The last year we did 144 transplants, And for Bristol, you can expect to wait just less than 3 years for a transplant.
Sam, we've got a member of the audience want to ask you a question live. Are you happy to take that?
Yes, of course.
Rudolph, hello. Are you able to speak?
Hi, Rudolph.
Talking is permitted. We should be able to hear you, Rudolph, but you'll need to turn your microphone on.
Hello?
Hi. Hello.
Hello, it's me, Christian. It's Rudolph's mum. Because I've got his iPad here. He's listening in the other computer there. I just want to ask, what is the procedure when you have a very big kidneys? Like I said, 3 kilos or something further. How is the procedure for the dialysis in terms of positioning and things like that as well?
Good. Excellent question. I'm just about to come on to that.
Sorry.
No problem. The next slides will hopefully show this. So I'll start with the one I showed before, showing the 2 of your own kidneys up there at the back, and then the transplanted kidney in its new position there. Now, if you'll again allow me a little bit of artistic license. There's a polycystic kidney, and you can see that it's filling most of the space there. And you can see that if you've got 2 enormous kidneys there, actually putting the transplant in through the cut that you made can be tricky, because the polycystic kidney can actually get in the way. So because of this, when you have polycystic disease, it does present unique challenges for us in terms of how we plan everything out, just as you've asked, Christiane. So I'll just talk about the way that we deal with it in Bristol. And I'll call it the surgical management of polycystic kidney disease. So what we're looking at, the people I look at are always people who have kidney failure or are about to have kidney failure. So if your function actually is much higher than that, so let's say 30, 40, 50, then you probably see a urologist rather than me up in Bristol. So your function level there is at 15 to 20, which is a little bit like a percentage. So the first thing for us to do is to prepare for hemodialysis. That means that we need to put a plastic line in your neck to access the blood, or preferably we'll create for you an arteriovenous fistula, which was that little diagram of the hand and the wrist I showed before. So we need to make the fistula first. That would be the ideal first step. The next step is to treat the symptoms that you're having. So most of the time that will involve removing the kidney that's causing the worst symptoms. It might be that the right one is the one that's giving you all the pain, or most of the pain. It might be that the left one is the one getting all the infections. Usually there'll be one that you can tell me is worse. And then I'll say, fine, we'll take out your left kidney. We can remove both kidneys at one sitting. I don't like doing that. Now, there's not international agreement on how best to do this. In fact, there isn't even national agreement on how best to do this. But my preference, and the preference in the centres I communicate with frequently in London, is to remove just one kidney. The major reason for removing just the one is because if you remove both of your kidneys, suddenly you produce no urine at all and have no kidney function at all, which some of you will know is not a pleasant situation to be in. If you've got even some functioning kidney tissue, it gives you a lot of advantage over having none at all. So let's say that your function was there between 15 and 20% at the top. We then made a fistula for you just in case, and we then removed your left kidney. We then monitor your function in the days following the operation to see whether you do need hemodialysis or not. Now, you might think that you would lose exactly 50% of your function, but of course, because this is biology, it's never quite as straightforward as that. And so some people will manage just fine, even with one kidney, and they won't actually need dialysis, which is great. Other people will, and we'll have to then establish the hemodialysis. Either way, it's important that we've prepared for it beforehand so that we're not very suddenly and urgently putting in a dialysis line. So after we've established that, after we've removed the most offending kidney, we then want to think about arranging a kidney transplant. Now, if there's someone who can give you a kidney, which could be, again, a friend, a relative, then that's fine, and we can arrange it in a time course of a number of months in ideal circumstances. Otherwise, we can work to activate you on the National Deceased Donor Waiting List and then get you a transplant when luck provides it, if you like. After we've got to that stage, some people then come back again to the clinic afterwards and say, actually, my other kidney is still bothering me. And we say, fine, let's now take that one out. Once you've had a transplant, it's likely that you're in a lot fitter and a lot better shape than you were before you had the transplant. So having further surgery at that point is a lot easier to recover from, if that makes sense.
Somebody's asking here, if you were to have one kidney removed and then one added, would you have two different scars? So surgery to remove the kidney and then later surgery to implant, to graft? Yes,
you would. And the reason is that to get the big polycystic kidney out, the most sensible way is to go straight down the middle. And then to do the transplant, the most sensible thing is to go with that sort of slightly hockey stick shape one, or crescentic shaped incision I showed you. Even if you did in fact have both operations done at the same time, often we would still use both incisions because they're completely different places in the abdomen. And sometimes it's nice to keep those two compartments of the abdomen separate, a bit like being in separate rooms in a house. So yes, two incisions.
A few questions about sort of incisions and scars here then. So if you were to have a second transplant, would you utilise the original incision, or would you create a new one?
For a second transplant, we always will go on the opposite side to the first one, if it's possible. So some people, it may not be possible, but if we can, we'll always find a new place to operate, sort of virgin tissue, if you like, so that we're not going through scar tissue. So let's say you had your first kidney transplant a few years ago on the left-hand side. If you're coming in for one now, by and large, it'd be very likely to go on the right-hand side. So the next question after that is, what do you do with the third one? Well, we then have to look for space a bit above the old kidneys. So we'd have to go on one of the sides that we've already used.
So he's saying then it's a case of looking for a place to accommodate it, then sort of big enough and close enough to the sort of relevant sort of vessels and so on.
That's right. In fact, it wouldn't matter which blood vessels we used anywhere in the body, but we like to connect it to the bladder, and so the urine will come out that way. Again, some people may have experience of not having a bladder. There might be some people listening, or you might know someone who's had their bladder removed, and then there are different ways that we can get the urine out.
So presumably the person that had several transplants, so space, I am assuming space would have run out at some point.
Well, as I said, the most I've seen with all the kidneys in was someone having their 6th transplant without having had any of the others removed. But yes, you're right, you can begin to run out of space. And so sometimes that means that we have to remove one of the transplants in order to make space for a new transplant.
Yeah, okay.
Okay, so that's the natural end. If there's a bit more time, I can talk a bit about the donor operation, or I can just take questions now.
We've got time. Do you want to take a couple more questions and then talk about donor? Yeah. So I've got a question here about fistula. Why do some people say they burst on dialysis when they, what do they mean by that?
I mean, this is trained in it. It's a particular skill to find the fistula vein. All it is actually is your vein made a bit bigger, a bit like a sort of a bodybuilder's vein, something like that. And yeah, the dialysis nurses are skilled in finding it and then putting 2 big needles in it. Now, sometimes the veins can get a bit wiggly, a bit tortuous, and sometimes they can dive deep, and that can make them difficult to put the needles in, despite our efforts to make it big. And sometimes that means you can put the needle straight through, or you can miss the vein a little bit. And sometimes that means that the blood can come out and make you a big bruise. So when people say that it's burst or blown, usually that's what they mean. The other thing that they could mean is that because the fistula has been there for so long and got so old, and I'm talking sometimes 20 or 30 years old here, that the fistula can start to erode its way through the skin where the needles have been put in and out over the years. And that can actually burst. But usually we have a lot of warning for that. The dialysis nurses will say, look, we think this one's at risk of bursting. And then they'll come and see us in the clinic, and then we'll do something about it.
Great. So, so a few people have asked today about sort of health screening prior to being listed for transplant. Could you talk a little bit about that sort of process, the sort of pre-listing process?
Sure. So we have to make sure they're going to be. So first of all, it'll be your nephrologist or your kidney doctor who will have brought the idea up, or maybe you've brought it up with them in the clinic, and then they'll think about it, and they'll probably have an idea in their mind as to whether they think that you're fit and strong enough. The process we go through, and we try and make it the same for everybody. We have to take quite a detailed history of all the illnesses you've had. We have to take a history of cancers, in particular, because once we've given you a transplant and we've put you on anti-rejection drugs, there's a chance that those cancers could come back. So we need to talk about the type of cancer and when it was and so on. If it was a long time ago, and by that I mean 5 years or more, it usually isn't a problem. So that's one major thing. The other thing is any infections that you've had in the past. And then we have to talk about your heart and your blood vessels. So any heart problems in the past, any blood vessel problems, any diabetes. And then if things have happened in the past, then we'll have to investigate your heart. And for most people over the age of 55, we'll have to do a study of the heart. And that's usually an echo, which is an ultrasound. They put jelly on, have a look at the heart and make sure that the heart is functioning within limits that we think are acceptable to put you through a transplant. So there are blood tests, there can be heart tests. Sometimes we run you on a treadmill as well. The other thing that we do is sometimes we put some special dye in a vein that makes your heart beat a bit faster to see how it responds to stress. It's almost like we're simulating the stress that you might have from having the operation. And then if you like pass all those tests, then we have a discussion together, and then we put you on the waiting list. Now I've had a particular interest over the past 3 years in trying to shorten that process and to use the figure of 18 weeks, which is used in many other specialties in the area of medicine. 18 weeks from the time that you're referred for a transplant to being activated on the waiting list. Actually, looking back, most people are hitting that, and so that comes out at 126 days. So it's not a short amount of time, but it's not a huge amount of time. And sometimes it's a sensible amount of time just to make sure that we've checked everything as well as we can.
So is that 126 days average wait time from being listed on the, or from that it takes to take somebody through the screening process to be
through the screening process,
yeah,
to be activated on the national waiting list.
Yeah. Okay. Thank you. There's quite a lot of people here talking about sort of post-surgery recovery. You mentioned time in hospital. What about sort of once they're back home? What's the sort of time period for people returning to work?
Usually about 4 to 6 weeks. It depends on how physical your job is. If it's office-based, a bit quieter, then I think 4 weeks is probably reasonable. If it's a bit more physical, then at least 6 weeks. Now, some people find that they're tired after surgery because it is major surgery, and that tiredness can persist for a few months. And by a few months, I mean possibly 6 months. Now, there might be some people out there looking back thinking, well, goodness knows, it was much quicker than that. Some people feel the energy and the burst from the kidney, even on the first day after the transplant. The fog is clearing and it's making them feel much better already. But others will feel the effects of having had surgery. So everyone's a little bit different.
Yeah, thank you.
4 to 6 weeks, you know, if I had to give you a figure.
Give or take, yeah. There's a couple of questions here about sort of success, transplant success, whether you're pre or post dialysis. Is there a difference between sort of success rates or recovery rates?
Again, this is another specialist, an area of interest of mine that we've published in. If you have your kidney before you've ever had to have a form of dialysis, we consider that to be the gold standard treatment. And the outcomes are better than if you've started dialysis. Saying that, if the dialysis has only been going for 6 to 12 months, that really doesn't make much difference at all. Now, it's not as if it's black and white. It's a sort of graduated thing. So let's say that the best outcome would be up here if you got the kidney before dialysis. Now, all the time on dialysis can just slowly bring the sort of brightness of that outcome down very slowly and very gradually. So if we can do it, yes, a preemptive, as we call it, pre-dialysis transplant is great. A short time on dialysis doesn't make a difference, but we like to avoid a long time on dialysis if we can.
Is that a good time to talk about? You were going to talk about. So was it live donations?
Yes.
Yeah, maybe that's a good cue for that.
Yes. Okay.
Okay.
So the next, yes, as we've got a bit of time left, I'll talk about the donor nephrectomy. Now, this is for a person, and there might be some of you watching, who's thinking of donating a kidney to someone else. So I'll start with the general process of it. Again, we're looking at 18 weeks of sort of screening and workup and having bloods, tests and scans and things like that. But then when it comes to the operation, you come into the hospital, usually on the morning of surgery. You meet your anaesthetist, they give you a general anaesthetic, and then we do keyhole surgery to take out the kidney. So these diagrams are similar, but they have some differences from before. So the one on the left shows the donor, and again, it has to be a very healthy person with normal kidney function. And you can see there some of those, they look like they're made of metal in there, and they are, the metal and plastic instruments. And you can see that the holes that they go in through are much smaller than the ones that I've drawn before. And those are the keyholes of the keyhole surgery, if you like. So we put those keyhole instruments through the small incision, and we take out the kidney, and then we put some dotted lines on the picture there to show where we have to divide the blood vessels and the ureter and free the kidney up from everything else it's attached to. And then the green line shows the route that the kidney takes, if you like. Now it comes out through, we have to make a bit of a larger cut closer down to your pelvis there, and then we pull the kidney out through that. We then move it over, we'd flush it as we did in some of those pictures before. And then the one on the diagram on the right hand side here shows the recipient, and that's the kidney going in through the incision I've described before. this is the idea of the position that you'd be in if you were having your left kidney removed as a donor. So you're lying on your right-hand side with the left kidney up. And that's again showing the keyhole instruments going in, shining a light on the inside so that we can find the kidney and then safely disconnect it from its blood supply, disconnect the ureter, and then bring it out through a cut a bit lower down in their tummy. And this is a real life picture. And these are the ports, as we call them, that are put in through the keyhole incisions. And there's one instrument going in through number 1 there. And this is the patient. Their head is up on the left-hand side and their feet are down on the right-hand side. And they're lying on their side facing us. And there's the monitoring shown behind them there. So that's the same picture again. So these are the example of the scars that are left behind afterwards, the little purple horizontal lines, if you like. And the keyholes are the smaller ones, and then the larger one is lower down there. That's the one that we pull the kidney out through. And again, this is about 6 weeks after an operation, while they've still got that pinkish colour, and in time they'll fade to white. So you can expect to be in hospital for 2 to 4 days afterwards, sometimes a bit longer. It just depends on you as the donor, how you are. We give you good pain relief. I'll mention the stockings here. Everyone who comes in for surgery gets a pair of stockings to wear. And the idea of that is to just keep the blood flowing through your legs and try and prevent blood clots forming, DVTs as we call them. So you get stockings and then little injections to thin the blood. And then the idea is just to get you back to normal, get you on your feet, get your bowels moving, get you eating and drinking, and then get you back home again. Now the recovery afterwards is a similar pattern. So we'd say 4 to 6 weeks usually off work. And then sometimes people can feel quite tired for up to about 6 months afterwards before you've got your sort of full strength back again. Some people it's much faster, but that's probably the longest recovery I've come across.
I noticed somebody raised their hand there, but then it seemed to disappear. If you wanted to ask Sam a question at that point, would you like to raise your hand again? While we've got him here, here's your chance to ask as many questions as possible. But whilst there is somebody here that has put a question into the Q&A, and this is: would you consider a live donor so is age limits an issue for live donation for the donor?
So we often have discussions about the extremes of age within the live donors. 3 years ago, we wouldn't take any donors below the age of 30 because we perceived that the long-term risks to them were too much. We've discussed that at length, and we've also had big national collaborations on this, and we've begun to bring that age down so that the lower age limit is now sitting at 25, but we will go lower with special considerations. At the other end, the upper age limit, again, there isn't a specific upper age limit, but once you get to the age of 75, we do start to become concerned that the risk to you as an individual might become unacceptably high. But we will take each individual for their own fitness. And certainly elsewhere in the country, donors in their 80s, people in their 80s have become live donors. As you get older, all the risks of surgery do become higher. But as I say, each person will be assessed individually, and we wouldn't say no just on that basis.
Equally, is there an age limit to those receiving a transplant?
Again, there isn't a specific age limit, and a lot of people that I see in my recipient assessment clinics are over the age of 70, which means that we're working them up over the age of 70, 71, 72 to activate them at that age. And they then have potentially 3 years to wait on the waiting list before receiving a kidney transplant. At the moment, it's unusual for us to begin an assessment for someone if they're already 75. But again, if that's you and you're interested and you want to ask about it, then please do go and ask your nephrologist, your kidney specialist about it and see what they think.
Thank you. Sam, there's somebody's raising their hand, like to talk to you directly. Is that okay?
Yes.
This is Tina. Tina, can you hear us? You need to turn your you need to put your mic on.
Hello.
Hi.
Sorry.
Hi.
Can you?
Just about, yes.
Right. I was just concerned generally, thinking about my son's diet. He's not having on a bad diet, but it could be improved. And I just wanted to know really if there is anything that he eats or doesn't eat that can cause the condition to be worse or improve the disease.
Yeah, polycystic kidney disease, yes.
Yeah, yeah.
I'm not aware of any particular foodstuffs or drinks that can affect the progression of the disease. The standard dietetic advice that you get will be provided by a renal dietitian in your local renal unit. But there isn't anything specific that's based in evidence that you should avoid for that reason. Now, if you have kidney failure as well, there's a whole list of things that you really shouldn't eat because they've got potassium and phosphate, other things in them that can upset the renal failure. But in terms of affecting the course of polycystic disease, I invite anyone to educate me on that because I'm not aware of any food that can affect the course of that disease.
Right.
Thanks, Tina. Any more questions specific to transplant that people would like to ask? Okay,
Hi, it's Tess. Do we still have a few in the Q&A?
Yeah.
There's somebody who's got a failing kidney. I don't know if you can see that one, Sam. With some rejection due to antibody. Asking about how long to wait for a new kidney. Presumably going back on the list.
Okay, yes. Well, if you've got a failing transplant kidney, then most units should have a process to treat you as if you were approaching your first transplant. So if it was kidney failure in the first place, and you'd need to go through the same processes again, the same screening processes, checking your heart, diabetes, and so on, to make sure that you're fit and strong enough to get another one. And it should be much the same as the previous transplant.
Somebody is asking here about, have you noticed a sort of a significant shift since the law change in terms of donor rates?
It's only just changed for us, so we haven't yet seen a change. What we've seen in Wales is a very modest increase in the number of donors. If you look all around Europe, in fact, it wasn't the opt-out system that made a big difference to donor rates. It was other things, including the organisation of the staff who identify donors. So what I anticipate, and what we haven't yet seen because we just haven't had the time, is a modest increase in the number of donor kidneys that become available.
Thank you. I think it looks like someone's asking a question about de-roofing. Tess, do you have that question?
Yeah, there was a question earlier about de-roofing. There's also a couple of questions about lithotripsy. I don't know if you've got any experience with stones and lithotripsy. I know it can be sometimes a problem in PKD. But yeah, de-roofing, yeah, that's comes up a lot because it's commonly done in the States.
Yes. Now, if we think that there's a particular cyst that's causing a problem, pain, infections, pressure, but we don't think that we need to remove the whole kidney, or we don't want to, then we can either ask one of our radiologists, an interventional radiologist, to use a scan to direct them and put a needle into that cyst. And in fact, that's what we most commonly do. But yes, de-roofing is something that I have experience of, although we haven't done it recently. That's generally done with a keyhole procedure, and you would go in through some small incisions and find the cysts and just pop them, if you like. And the de-roofing refers to sort of removing the top layer so that it doesn't just recollect straight away. And you could remove as many as you possibly could to make it smaller. And that would work in the short term, but in the longer term, the polycystic disease is still there, and so any remaining cysts will continue to grow. It also doesn't affect the course of kidney failure.
Sam, somebody wants to know whether you think the artificial kidneys are a reality at some stage.
Yes. Well, if we're talking about an artificial kidney, that suggests it's one of two things. One is it's made of artificial components, so something like a robotic device or a manufactured artificial device, probably made of metal and plastic, that you could wear or you could have implanted. I don't think we're anywhere near that. The second version is to grow one in a laboratory. Now, again, I've been interested in this. I've been in touch with laboratories around the world. The best that they've managed so far is to create a clump of kidney cells together in a ball that's grown, which is great, but it's not a functioning unit that can produce urine yet. There's lots and lots of work going into this. Most of the centres in the UK that are studying it are using scaffolds. So they'll create the scaffolding of a kidney, if you like, from proteins, and then try and convince cells to grow along that scaffold, and in that way create an artificial kidney. We're nowhere near having something that we can use yet. And if I had to put a number on it, it would be decades. And so 30 years at least, I would say.
Thank you. Still talking about live donation, there are many people that still believe you have to be a family member to donate. Is that a myth you can dispel for us, please?
Yes, you don't have to be a family member. Now, when we first started doing live donation, we used to call it live related because firstly, the people who came forward were all relatives to start with. But then we started doing what we came to call spousal transplants, and although they're related, they're not usually related by blood. The results that we find are actually no different. It doesn't convey any advantage, and in fact, if you look really, really long term in terms of donors, if it's an immune system condition that's causing the kidney failure, then there's a very slightly increased risk to that donor of developing that same immune condition in the future. It doesn't apply to polycystic kidney disease. We should know if you've got that or if you haven't once we've done the tests. But bottom line is there's no difference, and having any live donor is good.
Someone's asking here about because PKD is genetic. And this comes up a lot actually, is that people believing that PKD can then appear in the transplanted kidney, in the new kidney. Can you talk a little bit about that?
No. So the thing that causes the polycystic kidney disease in the first place is a problem in a gene that deals with the growth of kidney tissue. And that's not something that can affect the transplant kidney. The transplant kidney cells have come from another person, and those cells don't contain the same genetic code. And so there's no way that that kidney can sort of be infected, if you like, or affected by polycystic disease, because it's not in the coding of the genes in that transplant kidney.
Thank you. I think somebody asked about sort of the outcomes for transplanted kidneys, sort of deceased donors versus live.
Yes, the outcomes of live kidney donation are better in terms of the survival of the kidney and in terms of the survival of the person receiving the kidney. Both of them are much better than they were even 10 years ago. So what I say to people if they ask is, if you're getting a deceased donor kidney now, we can aim to get 18 years of function out of it from a deceased donor. And if it's a live donor kidney, we can aim to get hopefully 20-something years out of it if we're transplanted today. And the reason it's got better, and it's not because of anything to do with the operation, it's because of improvements in the drugs and the monitoring that happens over the following years.
Fantastic, thank you. We've got one more live question, then I think we're going to have to draw close. You happy to take that, Sam?
Yeah, of course. Any.
So this is, we did have. So Tina?
I think it's
hello,
Jane. I think it's Jane.
Sorry, I asked my question already.
I think it's Jane Becker.
Apologies, it's Jane Becker. Sorry, Tina.
Oh, okay.
Jane. Hello, Jane. Can you are you able to unmute? Don't know what's happened to Jane. We seem to have.
Whilst that's happening, there was one rather interesting question here, I think, Sam, blocking off the old kidneys, or do they still function or even have a function?
Blocking off, did you say?
Yeah. So tying off in some way. I suppose, especially if they're polycystic.
We normally wouldn't tie them off because they tend to still produce some urine.
Mm-hmm.
And so if we tied it off, then there'd be a backlog, and the urinary system would expand like that, but albeit very slowly. There are certain and rare emergency situations where you might have to consider that, but it's not something I'd recommend. Yeah, that's why we tend to take the kidney out.
Thank you, Jane. Are you able to talk? No, I think. No.
We still have, Jane Pugh, we still have Ash's question on lithotripsy.
Oh, sorry, Tess.
Surgical question, Sam.
Yeah, well,
maybe actually more urological. And
yes, it is slightly outside my expertise, and I don't refer for it or deal with it. But if it became clear that a stone was causing symptoms, pain, infections, and so on, then lithotripsy can be used to shatter them. I'm sure you've probably heard about it, but they use shock waves directed at you. You lie down in a machine, and they direct shock waves to sort of intersect to cause a reaction at a certain point in space, which they map in your body, and it shatters the stone, and then hopefully that stone can come out. But yes, it is more a question for a urologist.
Thank you. I think I think we could probably keep you here all night, Sam.
Yeah, I'll try and answer some of the written. I'll just type the written ones in the background if that's okay.
Oh, fantastic! Thank you. So, Tess, are we going to sort of hand over to you then to sort of wrap up?
Yes, yeah, it's fine. I just saying that a couple of people have also asked about how long do kidneys last, about ages of donation, etc. So NHSBT has just published its activity report for the last year, ending end of March. So of course it does cover the period when lockdown started and many units went into were closed. So you'll see that the numbers, of course, dropped away in terms of transplants. However, that is a very comprehensive report. We will send you the link out if you haven't already seen it, which covers by organ and by centre how many transplants were performed in the preceding 12 months from living donors and deceased donors. And there's also an indication of the outcomes. And there's also a fantastic breakdown of by age, by blood type, and by ethnic background. So it gives you a very comprehensive picture of the national transplant list, state of it, and who has been able to get a transplant in the previous 12 months. We'll send you the link to that later. Lots of data there. Somebody did also ask about whether units are open or closed. And again, there is a list of transplant units showing who's open at the moment for living and deceased donation. I think about 60%, 70% of units are now open. And some have been open throughout the whole lockdown, but a majority of them were closed. Very specific questions about conditions stopping you being a donor. There are a number of reasons why a person cannot donate. Those are listed again on NHSBT or organ donation website. Certainly your local unit should be able to provide that list. It does change from time to time and gets updated regularly. As Sam has said earlier, age is not always a barrier to donating. There was another question I saw about genetic testing prior to presumably living donation. It was mentioned in Dick Sanford's talk. It is available now at some units, but isn't done routinely. It's mainly if there is a young person who wants to donate, under the age of 40, let's say, where an ultrasound or MRI is not clear. So where cysts haven't been seen, or maybe it's not a very good image. Just to be absolutely sure that that young person doesn't have PKD. Could be a PKD2 patient, and therefore sometimes the cysts are not always visible. Then you can request genetic testing, and it should be made available. There should be no deterrence if there's a good cause to have that done.
Sam's still furiously answering people's questions. Right, thank you. This is fantastic. Tess, while Sam's doing that, there's a general question here. I wonder if this is someone asking about their husband who's experiencing extensive intestinal bleeding, which she seems to think has been caused by being on dialysis for 4.5 years.
Oh, that's a very specialist question to be addressed with his kidney doctor. Sorry, can't do that one.
Anything about, along those lines?
No, but it does remind me there were 2 other questions about dialysis choice that came up earlier, and from 2 different people asking about choice. Typically in the UK, when your GFR reaches about 20, you tend to get referred into what's called a low clearance or a pre-RRT, RRT being renal replacement therapy, clinic. So sometimes that's in a completely different part of the hospital. You start again with a new doctor who's a specialist in renal replacement therapy, and new specialist nurses. And at that stage, you should be given a lot of information and be provided with the opportunity to find out more about dialysis choices. Sam obviously spoke quite a lot about hemodialysis, particularly in the context of surgery. But of course, peritoneal dialysis is also an option for many patients with kidney failure, and is not a contraindication if you have polycystic kidney disease. There are still some doctors who feel that your kidneys will be too big and not really leave you enough space to do peritoneal dialysis, which involves a catheter being inserted into your peritoneum and fluid being introduced as opposed to removing your blood. Just by way of background, I'm currently on peritoneal dialysis, and in fact today over the lunch break I did my drain. It allows me to continue working and travel, and is a great option to consider when you get to the point of thinking about having to have dialysis in the absence of a transplant. Clearly, transplant first is the motto, and ideally everyone with polycystic kidney disease should get a preemptive transplant. But of course, if you have to have a kidney out or two kidneys out, then you will have to have almost certainly have to have some form of dialysis to enable you to get sufficiently recovered in time for a transplant. Just checking through some of the question and answer. There were a couple of questions about why do you get cysts in other organs apart from the kidneys.
Yeah, it's the same.
Something you mentioned earlier about cysts on the transplanted kidney, but of course the same thing that causes a cyst in the kidneys, the genetic abnormality, mutation, causes the cyst to form in many organs, in fact, not just the liver, which is the most familiar to PKD patients, but you can get them in pancreas. Men can often get cysts. They are rare cysts found in the brain, nothing like an aneurysm, but have been noted. Most of them are benign and don't cause the organ affected to malfunction. Sam, do you want to add anything to that? I don't know if you've got experience of transplanting a liver that's cystic.
Yes,
example.
As part of my training, I was involved with liver transplantation as well.
Mm-hmm.
Livers are a bit different. We, by and large, about 99%, we remove the liver and put the new liver in the same place. And that's because the liver is a much larger organ. And there simply isn't the space usually for someone to have two livers. It can be done, very rarely. But yes, if it gets to that stage where the cysts are obliterating the liver function or causing problems for the person, then liver transplant can be the best treatment for it. Sometimes we'll also do liver and kidney at the same time. But that would need special discussion. And we don't do liver transplants in Bristol.
Thank you. Here's a question, another question for you, Sam, actually. Can donor recipients remain on the organ donor list on their death, and can their organs be used?
What do you mean by donor recipients? Sorry.
So if you've had perhaps kidney transplant, liver transplant, but you obviously you may have a well-functioning heart, lungs, cornea, etc. As I understand it, you can continue on the organ donor register, and any useful organs, viable organs, could be then transplanted.
We can, and we have used them. Yes.
Mm-hmm. Yeah.
I've taken kidneys from lung transplant recipients, and so I imagine the opposite way around could be true as well. We just have to be sure that the immunosuppressive drugs themselves are actually quite toxic to kidney, would you believe? So over time, that taking those drugs can harm the kidney. But if they're still working well, as evidenced by the blood results, then there's no reason not to use them.
Thank you. We had a question here about trusts removing people from the transplant list during COVID, a large number of people were suspended from the list because their units were closed. As they reopen, they are now being contacted to ask if they want to go back on the list, or they've been contacted to say that they have been put back on the list.
Yes.
I think you've reopened quite recently, Sam, is that right?
Yeah, we opened about 6 weeks ago. So we
Mhm.
shut down completely at the beginning of the pandemic. And part of the reason we had to shut completely is because we've only got one hospital, and every specialty is within that hospital. There are 3 units that kept going throughout the pandemic. The reason they were able to do that was because they had a completely separate building that they could use to do the transplants. We have restarted, and we've started in a way selecting subsections of the people on the waiting list who we think will get out of hospital quickly, because to start with, we didn't want anyone to be in hospital for a long time. By the end of August, beginning of September, I anticipate we'll have everyone back on the waiting list who was on it beforehand.
Excellent. Right. So coming up to 4 o'clock. Seem to have covered off most of the questions now. If anyone has a question, please drop us an email, info@pkdcharity.org.uk, and we will go through them all just to make sure that we've either answered or that we're able to answer them if it's related to an earlier talk. So I'd like to thank you very much, Sam, and also for staying on much longer. We always find that transplant does attract a big audience and lots of questions. So thank you very much indeed for that. Hugely appreciated.
Thank you for asking me. Thank you.